Hi, I'm Jack Cush here at EULAR 2023 in beautiful Milan, Italy. I'm reporting on an abstract presented on day 3 from the JAKpot registries. It's OP0219, the incidence of MACE events in rheumatoid arthritis patients treated with JAK inhibitors compared to biologic DMARDs. The JAKpot registries we talked about last year, it's a combination of 14 to 20 registries, depending on which study you look at. But they have as many as 20 worldwide registries, most of them in Europe, a few in Canada. In this particular study, it's a compilation of data from 15 registries, and they're not quite done with their analyses. But what they tried to do was what we're seeing a lot of at this meeting is recreate the data set that led to the oral surveillance outcomes in rheumatoid arthritis and what that means for the risks associated with JAK inhibitors. They were going to recreate that in their many thousands of patients and see what the data showed. So 15 registers, multiple countries. There's no uniformity in data collection here, but they looked at patients who were over age 50 who had one cardiovascular risk factor as the inclusion criterion, and then sort of looked at what happened as far as the future development of MACE. They had 3 treatment groups, as not 2 like in the oral surveillance study. They had a TNF inhibitor group, they had a JAK inhibitor group, and included all the JAKs. They had 4 JAKs in that group. That included filgotinib and the other 3 that we have in the United States. TNF inhibitors, all 5 of them, and then other biologic DMARDs called OMA, abatacept, rituximab, the 2 IL-6 inhibitors. And again, they looked at the development of MACE events and VTE events in this study. In the 3 groups, they had a total of about, I think the number was, I actually don't know. I know they had 12,000 to 20,000 treatment initiations in this, so a lot of treatment courses. The groups were relatively balanced because of the multiple registry nature of this. There was a lot of missing data, especially with regard to DASH28 scores and comorbidity assessments. So that data was sort of inaccurate, if you will. In the end, they had, in these 3 groups, an event rate, the event rate being MACE, of 37 with the JAK inhibitors, 84 with TNF, 65 with the OMA, other other molecules or other mechanisms of action drugs. The incidence rate was about 2 per 1,000 patient years, and not statistically different between the 3. And the point then would therefore be, hey, there's no worse MACE risk with the JAK inhibitors compared to TNF inhibitors or the other mechanisms of action biologics. There's a small problem here, that in the oral surveillance study, the event rates in the almost 4,500 patients in that trial, 2 different doses on tofacitinib, 1 group that was TNF inhibitors, the event rates were 1 per 100 patient years, which is kind of on par with what would you expect with a high-risk cardiovascular population who has RA. In this study, it's a log lower. So why is there an underreporting? And then does that nullify the impact of the study? I think it does. I think that we can't look at this and say, hey, the real-world data here from all over the world says it's not that bad with JAKs, and it's not worse than TNF inhibitors. And they did look at other things like TIAs and DVTs and PEs, and there also was no significant difference between the groups. What you can say is that there's an underreporting of the data. A lot of missing data, an underreporting of MACE events had to be the case. RA is not that different worldwide as far as the future development of cardiovascular events. But nonetheless, the bias, the data that was accrued here was actually accrued prior to the publication of the oral surveillance study. And so it's not tainted by the oral surveillance study. And the limitations or the deficiencies in reporting are probably prevalent across the board. So the relative comparison of events, albeit underreported here, shows no real difference between JAK inhibitors, TNF inhibitors, and OMA biologics. And maybe that's good enough. But again, a lot of us want to look at all kinds of new data, say, that's not my experience, that patients get more cancer, more DVTs, and more MIs and heart failure events. And that's because you don't see the patients who were enrolled in the oral surveillance study. Over age 50, cardiovascular risk factor. But in fact, the people who get all the events were over age 65, had a prior history of MI, who are smokers. So again, you can't really match up the oral surveillance study, which is a well-done randomized controlled trial with a clear-cut question, to reconstructed databases that look back to see, is that what we saw? I think this is a deficiency of the JAKpot study. Let's see what others think at RheumNow. Take care.